if a doctor thinks estrogen is bad or uses first and second generation hormones, your hormone therapy may work a little bit in the beginning, but it will fizzle out, and there will be this exercise wheel of conventional medicine constantly trying to treat the symptoms of your hormone deficiency.
Welcome to the Rebel Health Coach Podcast with Tom Underwood. Armed with truth and knowledge, your journey to a healthy lifestyle can be obtained. Preventative wellness, quality nourishment, and daily fitness routines dramatically improve your outlook on life as a whole. And you'll find the support and info you need to accomplish a healthier lifestyle here. Together, we can empower each other along our journey to an amazing you.
Welcome back to the Rebel Health Coach Podcast. Marie, today's guest on this episode on menopause prevention, which is episode 47, I have Marie Hoäg back for the women's side of things. And Marie, let's start out with telling us a little bit about yourself and what got you into this hormone cascade field.
Well, thanks, Tom, for having me. It's always nice to do a podcast with you. As you know, I've been doing this for so long, well beyond 15 years now. I've been working as a clinical hormone coach in a menopause clinic, working with thousands of cisgender and transgender women and men. And it's been quite an experience going through these years with the evolution of hormone replacement therapy and the different types of hormone replacement therapies. I started this more as a patient, like most people who get into a health field, especially health coaching, where I had very bad menstrual cycles and endometriosis and severe PMDD and, felt like a crazy woman until I met a doctor that told me I wasn't crazy. I just didn't have enough estrogen. And so that really piqued my interest because, as I've said before on your other shows, that I was one appointment away from shock therapy. I had run out of antidepressants and anti-anxiety cocktail medications just so I can get through my days. And, it's just mind-blowing when you realize that you didn't have to live that life all those years when you actually get on some good hormones. But it has been quite a journey. This, didn't happen overnight.
Right. Let's go into a little bit about your education and your research regarding the hormones, and then we can move into your clinical background a little bit. But let's start with your education and your research part of this.
Well, I tell you, because I had such great clinical response with optimal estrogen dosing, my physician and I ended up working together because our careers coincided. When I saw what was going on in his clinic after working for him, I couldn't believe what was happening with the patient. Patients were coming back feeling better than they did the last time they were in. And that was the opposite of most physicians I've consulted in their practices. And so I said, hey, this is like 15 plus years ago. I said, hey, do you have any sort of credentialing in this? Maybe you should go get some sort of training or a certification to help make you a specialist in this field because you're pretty good. And he said, hey, I'm interested in that, and I'd like it if you did it with me. And so, I felt very privileged and fortunate going through the fellowships at the American Academy of Anti-Aging Medicine and the Institute for Functional Medicine and the Scripps Center for Integrative Holistic Medicine. It's really given me quite an education. Though I'm not a physician, I know there was so much I didn't understand, but there was a lot I was able to. And so we still continue to be conference junkies in anti-aging medicine and hormone health. So my education's been extensive and the research follows just based off of what I've seen. I wanted to know more. What is it about estrogen, and why is it that everybody's afraid of estrogen, and why is it that our patients feel better when they have adequate amounts circulating in their blood, women? And I couldn't understand this disconnect with watching the clinical efficacy of adequate hormone dosing and what I was researching. And so, but now the research I'm finding, there's a lot of research out there that supports adequate dosing estrogen, even low dose estrogen, the benefits of it. So I am thrilled with the research that I'm doing. And my current field of research right now, these past few months, has been when women are pregnant, estrogen deficient, and what happens to the baby in utero with gender assignment and transgenerational diseases like PCOS. So I'm real fascinated. There isn't a lot out there, but there's some. So that excites me.
That's an interesting subject. It's a whole nother topic.
It really is, because, when I started a transgender clinic and I just had the privilege of working with some great patients in the clinic, there's just been a boom in this generation of transgender patients and the gender neutral generation. And it's just piqued my interest in the doctors I work with. This has to have something to do with hormones in some regard.
Right.
Because so much is passed on from the mother. And when a mother is estrogen deficient or her gut microbiome is dysbiotic, she hands that down to her children, the endocrine deficiencies and the health of the gut microbiome. And so, this really, getting into really preparing to have children is a whole nother topic. What a woman should do, get your hormones down, get enough estrogen in your system, clean up the health of your gut microbiome. This is what you're handing down to your children. So, and I'm not so sure how much a woman can really change the damaged endocrine system that was transgenerational.
Right.
But how much ovarian preservation you can do, but eating a clean and healthy diet and a good lifestyle can certainly contribute to the health of the gut microbiome, which really affects the brain function and mental health, as you know, when kids grow up.
Let's talk about your clinical background before we dig into menopause.
One of the best jobs I ever have or had is this one with being a clinical hormone coach, where you see a woman coming in completely broken mentally and physically, where she can't cope and the depression is severe and she can't lose weight and her body's falling apart and she can't connect. And then you watch her through a transition, like a metamorphosis, as the hormones are optimized. As you know, we have to titrate those hormones up to that sweet spot. You can't just load a woman up from any hormone and call it good when that's not the way her body functions. You really have to titrate that dose up. And so listening to women along this process communicate with you what they're feeling and these transitional milestones that they go through is just so rewarding. And it gives me an idea about, gosh, when estrogen is in this range, this is how women feel. And when you hear thousands of patients communicating to you what's happening to them along the process of getting their hormones optimized to their personal sweet spot that works for them by whatever method of delivery of hormones. There isn't just one way to get a person to a sweet spot. There are several ways, but it needs to be in a titration format. But it's been life-changing. It really has. And it's just really, and this is what's really interested me with research with estrogen deficiency diseases, because what I'm finding is these things just really, these mental and behavioral health issues and physical issues just really don't exist in most women whose hormones are optimal. And so it has been fascinating, and it's been a privilege to me that women are very forthcoming with how they feel with this. And it's nice to be able to lead women along that path to that sweet spot.
And I mean, there's a lot of women out there that I'm sure are appreciative of that. And, that they really are misguided in a lot of ways by their physicians. I mean, I see a lot of things on my end where, because most physicians, let's be honest, they go by TSH, which is producing the pituitary to tell their body to produce other things. But, and so most physicians, when they run labs and they look at TSH, and it really is not telling you anything.
Yeah, you really do need some behind the scenes. I mean, the TSH is good just to kind of give you an idea about, should I look deeper? Patients with, thyroid issues from the get-go, you always want to check those behind the scenes. It is one of the hormones that we check too, because estrogen has a very intimate relationship with thyroid. And there's a lot of similar symptomology between thyroid function and estrogen deficiency.
Right.
Yeah, it's very interesting how modern medicine is evolving. And doctors they don't know what to look for. But a lot of the reasons for that is, how many doctors have you heard of that has learned all about how to manage thyroid in medical school.
Right.
None. I mean,
Right.
especially estrogen, doctors are purposely taught to be afraid of estrogen to keep women in a state of estrogen deficiency so they can write prescriptions for medications to treat the symptoms of it.
Right.
Really addressing the root cause of these things is paramount to get people well. And pretty soon women are going to stop running from physician to physician, these doctors that just treat the symptoms of low estrogen. It's like they're not getting any relief.
Right.
And they will call these doctors and say, hey, well, I treat menopause as an estrogen deficiency disease or perimenopause as an estrogen deficiency disease. Let's get to the cause of all these things and fix it at its core so you don't spend the other 2/3 of your life mentally and physically falling apart.
All right, let's dig into menopause. First question I have is, why keep a woman from menopause?
Yeah, I'm a big fan of menopause prevention. I never, would really believe it if it wasn't something I was witnessing. And that's exactly what happens in the clinic when you give a woman the right hormones dosed in the right amounts and administered in the right manner. You have to understand how estrogen affects the mind and body of a woman. And estrogen really affects every function in the female body from head to toe. It affects, every cell down to the nucleus. There isn't one function that isn't dependent upon healthy amounts of estrogen to do its job to its fullest capacity. So when it becomes deficient, no matter the age or what causes the deficiency, women will feel it in their mind, their brain. They'll see it in their behavior. They'll feel it in their body, the way they behave and interact with other people. Estrogen affects our eyesight, smell, our touch, the way we think, how we respond to others, how our body breaks down, and how our mind works. It affects our hair, skin quality, whether we're going to be fat or skinny, if we sleep, or what energy level we have. So when women lose their estrogen, their mind, their body, and their behaviors become dysfunctional. So that's why old women and women with ovarian dysfunction, no matter how old they are, they just go crazy. They're hard to be around. Their bodies fall apart. They get aches, pains. They get sick. They get allergies. Their gut, they get gut problems because estrogen dictates the health of the gut almost as much as food does. And then a dysbiotic gut will shut down the ovarian production too. But these women are difficult to be around because they just don't feel good. And this is what we would call hypoestrogenic, a woman has hypoestrogen in a state of hypoestrogenism. She's not producing enough estrogen. And so women that are hypoestrogenic are guaranteed to not only be depressed, but darkly depressed with feelings of being hopeless and in states of deep despair. They also have anxiety, social isolation, and that goes along with loneliness. And they get this deep loneliness and isolation. And so they tend to be they're pretty incapable of coping and handling things that come their way and pulling information up her head, asking them a question and having them be able to recall information. It's very difficult to make that connection. They don't like to be touched. They avoid intimacy, emotional and sexual or otherwise. They just can't deal. And so hypoestrogenism or estrogen deficiency really refers to a lower than normal level of estrogen, the primary main sex hormone in women. I mean, this is the hormone that tells women, like you've heard me say before, whether they want to live or die. And so when women don't have estrogen, they just feel horrible and they want to die and their body falls apart and they lose their menstrual cycle. When women have healthy amounts of estrogen, they maintain a healthy menstrual cycle. And this is how we know if a woman is relatively healthy, is this menstrual cycle. Okay. So hypoestrogenism can be reversed if you can restore or maintain a healthy menstrual cycle. So a good way to know, as you've heard me say many times, a good way to know if a woman is estrogen deficient or not is the health of her menstrual cycle. Is it regular? Is there symptomology, cramps, mood swings, migraines, headaches, sugar cravings, carb cravings? I mean, it's like, well, I don't know. Why would a woman want to be in this state for 2 into their life. I mean, why wouldn't you want to avoid this? And you can, clearly, we now live in a day, I mean, Dr. Robert Wilson, who wrote the book Feminine Forever, talked about this. I mean, this is really where I heard about this, is this menopause prevention. As soon as I read it in his book, I'm like, what? You can do what? And I'm like, sign me up.
Right.
And that's just been, I've been in a state of menopause prevention, and I've seen women go into a state of menopause prevention. You give a woman healthy estrogen and they restore their menstrual cycles, then they're not going into that mental and physical decline. They don't have the same behavioral issues or coping issues. So it just depends. I mean, I don't know. If you were a woman, would you want to go into menopause?
I don't know. I can't answer that question because A, I'm not a woman, and B, I don't, I think, I wouldn't want to go into the depression. I wouldn't want to feel like that. But again, there's a lot of women go through unhealthy menstrual cycles.
Well, then chances are their estrogen's low.
Exactly.
I mean, it's those two correlate, and that's what doctors aren't taught. Doctors should be asking these questions in their new patient appointments, their initial appointment with the patient. Tell me about your period. Tell me about the crazy. Doctors are just quick to write prescriptions for antidepressant and anti-anxiety medications.
I will not disagree with that. They hand that stuff out like candy in a candy store.
Oh, no, yeah, they do. They're constantly writing them, but they're not addressing the root causes where it's coming from.
Right.
They're just very quick to write. It's like, oh, you have depression? Here, take this. It's like, but wait, but I can't. I've got blood clots that I'm giving birth to every month. Are we not going to address my menstrual cycle? It's like, oh, well, you can be OB-GYN for that. It's like, there's just this disconnect with a woman's true body with what physicians are being taught. This whole disease management approach just doesn't work very well for women or men.
Right. And they really don't, when they're handing out the antidepressants, they're not addressing any downstream effects of the pill that they're handing out either.
Oh, which creates more broken ovaries and more ovarian dysfunction and creating a, more severe state of, hypoestrogenism. I mean, it's like, you have to ask yourself, why are these doctors being kept in the dark? Why isn't this being discussed in medical school? Why aren't we using, restoring estrogen as first-line therapy to most of these?
That's a good question. That's a very good question. Why aren't they discussing that?
Well, why do you think, Tom?
Money.
Well, yeah. I mean, there's a lot of money to be made at managing symptomology. And women, they have a lot of symptoms. I mean, they have a lot of symptoms. I mean, I can't tell you the last time I've been on an well, I can tell you, before I had my hormones balanced.
Right.
But I was told that I was going to be depressed for the rest of my life, severely depressed the rest of my life, and that I would need to always be on medication or get some sort of shock type treatment or those types of things to function. And that's just for survival. That's not, and nobody even said anything that I feel good.
Right.
And that in and of itself is depressing. Because I wasn't who I felt I was on the inside. I just felt like I was just this disease of depression. And then the anxiety that accompanies that, where you just can't depend on yourself because you can't cope.
Right.
It's horrible to be, in that place. And I spent many years that way. And a lot of women do. And they're suffering. And they shouldn't have to. And there will be a time in a movement where women will get the right information and they'll be put on the right hormones, and there will be a movement demanding for adequate dosing estrogen and no more of this symptoms treating estrogen deficiency symptoms with these toxic drugs and treatments that create more dysfunction in our brain and body. This is a very sensitive subject for me because, I felt like this was my life, and it is a dark, lonely place when you start thinking that you're better off not being here. And that's not a good place to be. And, those things just don't come to mind when women have enough estrogen.
And to your point, that is why I do podcasts like this, so that the word gets out that there's a better way.
Yeah, there really is. I mean, there are several things that cause severe depression, but on the top of that list, I have to say estrogen deficiency.
Right.
Being in a state of hypoestrogenism, really, it coincides with, it's indicative of depression. It's just, that would be one of the things I would look for. And that's one of the things that is in our teaching curriculum for physicians is, you need to ask your patients about their menstrual cycle. And this is going to lead your entire treatment plan for your patient.
Okay. So how do you keep a woman from going into menopause?
Well, the goal is to prevent.
Okay.
We want to prevent. So, and there's some doctors that talk about, you can take hormones in a certain window, and that window is like post-menopause, when a woman has already lost all of her estrogen and given low doses to treat the horrible symptoms she's going to get until her brain completely shrivels up to nothing and she surrenders. So that's not really the window that we look for. The window that we feel is best is, anytime a woman is estrogen deficient who's post-pubescent, if a young woman has a horrible menstrual cycle and she's in her 20s, the goal is to regulate that menstrual cycle and maintain that menstrual cycle indefinitely. But the majority of women that I see are perimenopausal women in their somewhere between 30 and 40, whose bodies are in the beginning of the decline as the hormones decline in women's 30s. And the goal is to really prevent the decline from happening. So if you restore hormones that mimic a woman in a state of reproductive prime, then a woman doesn't go into a decline. She doesn't go through the perimenopausal transition into the cessation of menses that leads into menopause. So if you can restore with a good hormone regime, the right hormones, like you've heard me say, dosed in the right amounts, administered in the right manner, coupled with the right diet and lifestyle to enhance the clinical efficacy of those hormones, you could maintain healthy reproductive state. Well, even you won't be able to reproduce because a woman can't get more eggs. Once you're out of eggs, you're out of eggs. But you can restore a healthy menstrual cycle indefinitely for a woman, and it's easier to do that before they actually lose all their estrogen and peter out, losing their menstrual cycle. So the woman without the menstrual cycle is a woman without estrogen.
Okay.
And so our goal is to restore that state of reproduction through restoring the menstrual cycle in a healthy manner. Not like when I tell women we're going to restore their menstrual cycle, they freak out.
Right. I was going to say.
Well, I'll tell you who freaks out. Not all of them do. And it's funny because you can tell women you can tell the women who have been estrogen deficient for a long time, because when I say that, they freak out. I've had women get up and walk out the door before because they had such horrible menstrual cycle periods. They're painful and horrible, and mood swings are crazy. But the women that who have maintained healthy levels of estrogen most of their life, they just kind of shrug, okay, like it's nothing. And so it's kind of interesting, the response, like, oh my gosh, no. It's like, hey, it's not supposed to be this kind of menstrual cycle. It's supposed to be a light to moderate flow with a peak at day 3, shutting off by day 5 with residual blood day 6 and maybe 7, without incident, without the crazy, without the bloat, without the lower back, without pain, without the blood clots and the cramps, the mood swings, all those things. Those are all symptoms of low estrogen. That just means that there just isn't enough estrogen. And so that's the goal, is to restore that healthy menstrual cycle. That's how you can keep a woman from going into menopause. And you can restore a woman who's been post-menopause to varying degrees. It depends on how long they've been without estrogen.
Okay.
So you can start hormones in a woman at any time, but post-menopausal women, you don't get the same effect, because once the body and brain has done its shriveling, it's very difficult to resurrect those tissues in the brain.
Okay.
The goal is to avoid that shriveling up of the brain and the tissues.
Okay.
But I'll tell you, it's better. Postmenopausal women benefit significantly with being on hormones that are just right to the point of having that menstrual cycle. And those women are not the crazy ones. They're the ones that with a smile in a store and at peace they will people. Estrogen makes a woman happy. It's just all good.
Yeah, I'm not even going to go where I was going to go, but
well, that's a hard thing to respond to because there's a lot of women that are not happy.
Right.
And a lot of women have malcontent and nothing makes them happy. Even if they think if they achieved something, they would be happy. No matter how hard they try or they get that or they this promotion, this car, this house, this vacation, this whatever, keeping up with the Kardashians. I mean, it's just not until a woman gets enough estrogen that she's truly content. It's the anti-malcontent hormone is estrogen. Estrogen calms the mind of a woman. It's neuroprotective. It gives her a sense of peace and contentment with her world and her surroundings, especially when it brings back the self-esteem, self-worth, self-confidence, and the ability to handle things. And when you have all those things together and feeling good at the same time, it's women just kind of go about living the lives they actually want instead of trying to be that person deep inside. That person comes out like watering that person with estrogen, and then they blossom into the woman who they know that they are. They know they are, but nobody knows because they're dealing with all the crazy that estrogen deficiency brings.
That's interesting. And I mean, the big joke between, when I remember my ex-wife would be going through her periods and be crazy, it was like, all right, I got to get out of the house.
Yeah, I mean, a guy can only handle so much of that, Tom.
Right.
I mean, it does get crazy. And let me tell you, she doesn't like it. She probably didn't like it either. Women don't like behaving that way. We don't sign up for that. We don't want that. That goes against how we feel on the inside. And we can't explain these things. I mean, you can't control the things that come out of your mouth when you don't have estrogen. I mean, it's very difficult. And some of those things can be very bitter and sharp and damaging. And it's really hard for some people to get past some of the horrible and horrific things women say with their sharp tongue. Women with estrogen, they don't have a sharp tongue. I'm not saying that they're pushovers, but they're just not responsive like that. There's just this. That is just this, it's almost like a state of survival, that it's just like they're just clawing at trying to just get through the day. And anybody that crosses them, it just is in the crosshairs.
Right.
And then when it happens, believe me, women, they'll go off into the closet in the fetal position and absolutely fall apart and have these crying spells because they're behaving in ways that they are not them. And they don't understand why they're acting this way. And they feel bad. And at the same time, they're doubled over in pain with menstrual cramps, and they can't stand erect because they're just so doubled over with PMDD symptomology. And this just doesn't have to exist. And so when I look, I sound like your ex-wife. I mean, it's like a lot of women have gone through that. Most women have gone through that. And I feel bad for that. And I've apologized to my exes now that I have adequate levels of estrogen. I don't have mood swings. My emotions and responses are very appropriate to the situations at hand. I could, do my stuff, but you always know what you're going to get. You always know it's leading it. I mean, you can clearly provoke me, but it's not going to be so completely outrageous that the lamps are going to come falling down and things will across the room. That's those rages, those just instinct. And I know you've lived long enough to see a woman go into a rage.
Oh, yeah. A few. Just a few in my time. Just a few.
I'll tell you, that is having that loss of control for me was such a loss. And the way that people looked at me when I would do that. And I felt this helplessness because I felt like I couldn't control it. But I also saw the impact it had. And that made me feel worse about myself, and trying to repair that damage is very difficult because people can only love you so much. I mean, they can only tolerate so much. And the people that will just love you till the bitter end, they'll do it from a distance. And then you end up lonely and isolated from friends and family, and even pets will run from you. So it's a horrible place to be, and it's hard not to tear up when I say that, because it's a horrible, isolating life that most women are subjected to.
Right. And I've known guys in the past that track their spouse's cycles so they know when they're going to go fishing.
And they shouldn't have to tolerate it. They should be actually a support source, encouraging them to buy good, healthy foods and cleaning up their diet, and encouraging them to exercise with them. I mean, they can certainly be a partner in this to varying degrees. Because as you know, you can't tell your partner anything.
Well, I've got a lot more questions here, but before we go into the hormone sweet spot, let's touch base on one thing that we haven't really touched base on yet, and that's the importance of your gut health, which you just hit on the head when you said that. And I mean, it's very important to have a healthy gut in all this.
And I have to say, it's about time this conversation is being had. So there have been some spearheading gurus over the years who give lectures on the health of the gut. But really, the field of anti-aging medicine and functional medicine is really coming to the forefront on this gut health and the health of the gut microbiome. That gut microbiome, if people understand it, it's a living thing. It is the largest ecosystem in this universe. And it has been handed down thousands of years, generation after generation after generation. So when you have a series of transgenerational gut dysbiosis that's handed down, that the health of the gut really dictates the carbohydrate cravings, the sugar cravings. It dictates hormone levels. A dysbiotic gut will shut ovaries down and create dysbiosis, and vice versa. Estrogen deficient women, estrogen deficiency creates gut dysbiosis. And so really taking a look at all the things that affect the health of the gut microbiome. And for your listeners who don't know a lot about this whole gut health thing, to simplify it, you have healthy bacteria in your gut and you have good bacteria in your gut. And the goal is to have more healthy bacteria, a diverse healthy bacteria. And we do need some bacteria, but just a little bit, like a garnish on a plate, not a lot compared to the meal. So when people eat foods like, for example, pasteurized milk, we put our patients on raw milk. Pasteurization takes out all that good bacteria that feeds and makes the good bacteria grow, and the only bacteria that's left is the bad bacteria. So drinking unpasteurized milk actually waters that bad bacteria in the gut like a weed. But people get so bloated, when they eat citrus, or people who drink flat water and get nauseous. That's one of the signs of dysbiosis. And so people with a dysbiotic gut have a hard time drinking regular flat water. They usually go with something with carbonation because they can tolerate it. But the health of that gut just dictates disease and inflammation. So it's extremely complex. And but there's a lot of great research out there, but it certainly does affect the hormone levels in both men and women. And so we don't even approach optimizing hormones until we discuss preparing that gut for hormone replacement therapy. Right. We found that when women have severe dysbiosis and you give them hormones, they're going to feel bad for the first few months. They're going to feel good, but they'll have some symptomology. They're going to get bloated. They're going to get breast tenderness. They may gain some weight because they're not able to detoxify their estrogen appropriately because of dysbiosis. And they don't have regular bowel movements, so they're reabsorbing the estrogen that's in their stool, in their gut, and in their tissues, reabsorbing it, and they continue to create an estrogen dominance effect. And I didn't mean to go off on a tangent on that.
Right.
But that all works together. So, we no longer just give patients hormones without first addressing the gut. This is something learned in the clinic. It's just so women, the efficacy of adequate dosed hormones is dependent upon the health of the gut microbiome of the patient. So that's why we have to address it. So patients that come in that have eaten nothing but farm-to-table foods with plenty of animal fats and unpasteurized dairies and uncured meats and fermented foods, those types of things, that really nurtures the gut and helps balance out the gut microbiome. So when you give these hormones, they work so much better and they're more clinically effective and they get to their sweet spot a lot quicker. All
right, sweet spot. Let's go there. What is a hormone sweet spot?
What is that? Well, for me, it's a clinical destination. It's a place. It's true hormone balancing. It's when your hormones are properly balanced. And I'm not sure if there's very many people that can tell you what does that mean. Can anyone tell you what it means to be hormonally balanced? What does that mean?
I think it's different for everybody.
It is, but how does a woman know when she's hormonally balanced? What's that criteria? Have you ever known a woman say, "Oh yeah, I'm balanced. My hormones are balanced. I feel good."
Nobody other than you.
Well, that's because they are.
Right.
I mean, and there's a measuring tool for that. And, and this is what we've learned over the years. We're not just sitting around, putting hormones on patients and doing nothing. And people have responses. When you give them healthy hormones, there are things that happen to them. And there is a clinical algorithm to get a person to their hormone sweet spot. And it just depends on the type of hormone replacement therapy that you use. For me, what I consider my hormone sweet spot is when we measure clinical indicators with blood serum levels. And so this is how we determine the sweet spot is how does the patient feel? What are the clinical indicators? And where are the hormones? And so the handful of hormones that we monitor and supplement, there are particular ranges that we found over the years that women just do their best. And when women fall out of this range, we see what happens to them. And when they are maintained in this range, we see what happens. And when it's too high, we see what happens. And so there is a sweet spot. And when women have their estrogen is low, they'll feel it. And when it's too high, they won't feel good either. And so there is this sweet spot. For most women, it's in clinical range that we measure mostly estradiol, FSH, and some other labs. And we monitor the symptomology along the way through the process to the sweet spot. So there is a dosing titration that takes place with the hormones that leads to a clinical goal. And most women do well in the clinical goal. So that's where we shoot for first. But some women don't need as much to get to that goal, and their range may be different. But most women, 80 to 90% of women do real well with a particular range. And then so the clinician that really understands hormone dosing will understand how to adjust the doses in the women in other ranges. And there are just some women that hormones just don't work. I mean, there is a small percent. I'd have to say there's probably a 5 to 7% that no matter what you do for your patient, it's just not going to work. And for different reasons.
Okay.
We see, to answer your question, what is the hormone sweet spot and how do you get there? The hormone sweet spot is when a woman can't imagine feeling any better than they do, and they have very few negative clinical indicators, and their blood work concurs with that range that women seem to do well in. And so that's how we determine the sweet spot.
Okay. Is there an optimal range, or is it just based on individuality?
It's both. We found, when you're working with several thousand women over the years and you're matching up clinical indicators with blood work, you kind of see, like I told you, when we first started, we had just a basic symptoms questionnaire that women rate their, 18 to 20 different clinical symptoms from 0 to 4, from like migraines, mood swings, depression, anxiety, to those top clinical indicators of estrogen deficiency. When those women fill those forms out every time they come in, you see a change in these numbers. And each time they fill out one of those questionnaires and we take labs, we correspond those. And they're very much in real time. You can really correspond real well with those ranges, and I know I'm not making sense here for a moment, we know that most women tend to do well when their FSH is suppressed under 5. We also know that women do real well when their estrogen is maintained, their estradiol is somewhere maintained, depending on where you take the blood work. If you take estrogen at its peak on day 12, most women tend to do real well somewhere between 350 and 550. And I know that's what works for me. There were times when I maintained my estrogen somewhere between 6 and 800, but most women tend to do well in this range. But some women require less and feel good with a range that's below that or a range that's actually above that. But, the majority of our patients, we look at that particular range.
All right. We discussed the reference ranges for hormones, but I also want to dig into a little bit about the 4 generations. So we've touched base on them, but the 4th generation is where we're headed. I want to touch base before we move forward because we're going to talk about Wiley protocol coming up, but I want to touch base on the 4 generations. So could you go into that for me, please?
Oh, yeah, I'm happy to do that. It's a term I coined only to describe to patients the different types of HRT in our office. Because women will come in saying, oh, I'm on hormones. Well, not all HRT is the same.
Right.
And we've worked with every type of HRT on the planet with the exception of pellet therapy, of which you and I have gone into before. And to really understand the differences in these HRT, I believe is important for women to understand so they can find a doctor that does the type of hormone replacement therapy that they think they might need. And so this is why I broke this up. So first generation HRT is what I would consider the old school hormones. The Premarin, Prempro, the synthetic hormones designed to treat the symptoms of estrogen deficiency with low doses. It's administered in a static format, meaning the patient takes the same dose every day. And the goal is to have the patient take it for the shortest amount of time. So these are your synthetic hormones, including birth control pills that doctors think birth control pills are hormones. It just drives me now. I'm on birth control. What hormones? Birth control? I'm like, honey, you're not on hormones. You're in chemical menopause.
Exactly.
Second generation HRT is the differentiating factor. The biggest one here is the bioidentical hormones, the compounded creams, the plant-derived hormones that are derived from a Mexican wild yam. And though these are not, they're considered natural hormones, and the term bioidentical means that the molecular structure mimics that of a human molecular structure. So there is some synthesizing that takes place with bioidentical hormones so that we can match that plant molecule with the human molecule so that the women's body thinks it's its own. And so this is the biggest differentiator in this generation. And this is where you have the compounded creams. There are some bioidentical hormones made by pharmaceutical companies like Evamist, Estrozorb, even the patches, sprays, gels, suppositories. And these are all low-dose hormones designed to treat the symptoms of estrogen deficiency, again, with the lowest dose for the shortest amount of time, but nobody knows what that dose is and how long that time is, or when you adjust that dose. Though they do say adjust the dose according to the patient's symptoms, but it's all low dosing. And so there tends to be this static dosing, same dose every day. So there tends to be, this is where what I call crapshoot HRT, where women are seeking out doctors that do bioidentical hormones, but there's no real formal education or training in how to use them. And so women are just running from doctor to doctor, trying to find a doctor who might know how to do it better than the other. But this mindset of keeping the hormones low forever and the same dose every day just fizzles out receptors, and we just don't see good clinical efficacy. They stop working in about 4 to 6, sometimes 9 months if a woman is lucky, because it doesn't trigger a receptor response. And this receptor response is one of the biggest differentiators in the third generation HRT, is dosing the hormones not in a static format, but in a rhythmic format that mimics the natural physiology of a woman's hormone, the hormone itself. So you would dose the hormones according to that particular hormone type cycle. So the dose at day 12 of estrogen is going to be different than the dose at day 18 and day 21 and so on and so forth. This peak at day 12, if the dose is correct and the dose is high enough for long enough, then you trigger a receptor response for not only estrogen receptors, but for progesterone receptors, thyroid receptors, testosterone, growth hormone, cortisol, melatonin, insulin. So estrogen regulates insulin. And it's because of this receptor response that you get here at this peak. And then the luteal peak and the progesterone peak in the luteal phase downregulate these receptors so women can shed the lining of their uterus. So this is the biggest differentiating factor, as well as how much is dosed, how it's dosed, and when it's dosed. And so the goal is to mimic the natural hormone physiology of the hormones that women are taking. And one of the brands of this particular generation is the Wiley protocol. There are other doctors who have, tried to manipulate this protocol and have similar or have had to make up their own rhythmic dosing because they see how clinically effective it is, and they come up with their own. So there's some independent doctors doing it, as well as the Wiley protocol is one of the brand names. And then the fourth generation is really a deviation or really derived from a Wiley protocol. What we found using the Wiley protocol, like I was telling you before, we use every method of HRT, including the Wiley protocol in the clinic. And so we've seen the clinical efficacy of all these generations of hormones and how they work and when they stop working and why they stop working. And we found that the Wiley protocol has quite a few clinical flaws to it. And we found that it was only effective if we dosed the hormones according to the recommendations that Wiley insists doctors to use, then it only works on 20% of our patient base. And so there aren't too many successful Wiley practices across town because of this. And doctors, like the doctor and the clinicians I've worked with at the menopause clinic, we paid attention to these clinical flaws and found ways around most of those flaws. And, and we did go to Wiley with this, asking her to make the adjustments so that we could use her hormones on more of our patients. But she took offense and said, "No way, Jose," in a few choice words. And we said, well, we can't keep saying that we use your protocol when, because she threatens to sue doctors for patent infringement if they don't prescribe her hormones the way that she has the patent set up. And we just said, okay, we just can't use her protocol anymore. So we have to use our own. And so that's where we came up. We fixed with the clinical flaws that we've fixed, most of them anyway, that we get better clinical results from a fourth generation HRT. And that's where that was the birth of Panacea HRT.
Okay.
Is this fourth generation HRT. And we are not the only people who come up with their own protocol out of the Wiley protocol.
Right.
She can she can keep her protocol, but other doctors who see, because she's never took this to the clinic before she really launched it, her protocol.
Right.
So then these doctors that are working in the clinic using it, saying, hey, wait a second, this is where it fails, and this is how I think it can be fixed. Well, she's not interested. So what are doctors supposed to do?
Right.
Especially these, spearheading doctors, like Dr. Meehan and Dr. Nagel and other practitioners who say, hey, I'm not going to keep my women, my patients, estrogen deficient, so let me give them what they truly need, because this is where I see it clinically. You actually see the patient in front of you saying, this is how I feel, and these are the labs. And so you can't really argue with that. And so that's in a very large nutshell,
right.
The four generations of HRT. So I hope I explained that.
Yes, it does. As you may or may not know, this podcast is proudly sponsored by AgeForce.com, bringing traditional health supplementation to the modern era. For thousands of years, people have been using skin application methods to naturally and efficiently absorb food, nutrients, and various other substances to support their health and fitness. AgeForce is no different, delivering breakthrough, time-release skin patch products that maintain the integrity of traditional health enhancement methods. Age Force helps people maximize their HGH levels, manage their weight, control inflammation, boost amino acids in the body, increase intake of vitamin D, boost libido, enhance memory and focus, energy levels, melatonin, testosterone, and we could go on, but we'd be here all day. A quick visit to the Age Force website will show you streams of 5-star reviews proving Age Force's ability to change lives. Transdermal application differs from oral in that the vitamins and minerals are delivered directly to the bloodstream, a much more efficient way to boost your health and get the maximum dosage possible. Visit ageforce.com to learn more. Here's a question. This goes back to second generation, but these are used a lot by a lot of physicians, and that's pellets.
Oh.
I know, that's my thought exactly. It's like, really?
Yeah.
But from my point of view is you can't just put something in somebody's body and expect it to dissolve on a timely fashion or dissolve when you want it to dissolve.
Yeah, that whole concept is a very male-driven, I have to say. Let's just load them up. What I call them a load them up and let them fall method of HRT, because you can't just like fill up a woman with estrogen like it's gas in a gas tank. I mean, and just think that she's going to be okay for 3 to 4 months.
Right.
And then pellet therapy for women is not about estrogen. It actually creates estrogen dominance. What people don't understand is when you load a woman up with testosterone, thyroid, and progesterone, and you just give it to them like that, nobody is addressing the main sex hormone of this woman. It's like giving a man loading up, we're not going to give you testosterone. We're going to load you up with estrogen and progesterone and thyroid and see how that guy handles it.
Right.
I mean, it's like that. When you give a woman such a large dose of testosterone, it changes the brain into thinking she's a man. This is what we do with transgender patients. You've got to give them enough of the hormone of the sex that they say that they are. And when you do that, it changes their brain. It actually sends signals throughout the body to make those changes into that gender. And it just, pellet therapy really has me fired up because it really makes a mess of women. Their hair falls out by the handfuls. They become very difficult to live with because they get into a state of fight or flight, because not only are they more estrogen deficient than they were, this type of HRT puts these women in a state of estrogen dominance because they don't have enough circulating estrogen in their blood to naturally detoxify it. Then these women get constipated. They can't poop. And then they start to reabsorb the estrogen, and they usually have dysbiotic guts because they crave carbohydrates and sugar, and they're not sleeping, and they eat these foods to cope, as well as they're craving them, which creates further dysbiosis. And then with this dysbiosis and the lack of pooping, the phase 3 detoxification, then women are reabsorbing these estrogens they can't get rid of into their body, creating more estrogen dominance and the symptoms that go with estrogen dominance. So this makes a woman totally crazy. And so to me, you've heard me say this before, and I know that malpractice is a very strong word, but this just does not make sense. If somebody that would be so cruel to load a woman up with the opposite sex, a male main sex hormone, and not address my main sex hormone, and creating this response. And how these doctors are not listening to their patients in follow-up. It's like, when's the follow-up appointment? I mean, when do they listen to the patients complain about, oh my gosh, I'm everything in my life and my world is falling apart, including my mind and body. Like, and I don't know what these doctors are saying to these women. Oh, hang in there. I mean, I don't understand what they're saying. And I don't understand how they can retain these patients, to be honest. But I know these doctors, I go to the same conferences, they are sold. There's a lot of money putting into the selling of pellet therapy. And it's one of the only HRT systems that has training and education. So I know that that's a big draw for physicians. They're like, oh, okay, well, it sounds like you guys have it all down. Really? Where did this method of HRT come from? And who? It wasn't from a woman. And it wasn't from a hormonally balanced woman. Because a hormonally balanced woman knows where that needs to be.
They would be doing that, right?
Yeah. Yeah, that'd be the last thing I'd recommend. As a hormonally balanced woman, I would never recommend that to anybody, not even to a man. And that's just...
I don't see how it could possibly work without failing.
Me either.
Just by the logics of it.
Over and over and over and over. And they come in saying, I'm on pellet therapy. And we're like, oh, we're so sorry. You know?
Well, it seems to be like the go-to for these days.
Because they're sold. These doctors are sold. Doctors are very vulnerable at these conferences. They are searching for ways to balance hormones. And when you have people spending thousands of dollars, tens of thousands of dollars in sponsorship advertising, saying, hey, we'll teach you. I mean, the pellet therapy booths are large if you go to these. They spend a lot of money wooing these physicians. Oh, we'll teach you. They don't teach them how to balance hormones. They teach them therapy.
But not only that, it's easy. They sew the pellets in the butt, and then they let them go, and come back, and I don't know what the turnaround time is, but
okay, you've seen that illustration of the cockpit for a man and the cockpit for a woman. And the cockpit for a man is an on and off switch,
right?
And the cockpit for a woman is this vast array of knobbies in an aircraft,
right?
And then so you've got guys who have developed an HRT system that is like a light switch to them. And they think it's supposed to work for women.
Right.
It's like, didn't they read Men Are From Mars, Women From Venus?
Apparently not, because it doesn't work.
Yeah, it's like women do not work that way. Their brains don't work that way. Their bodies don't work that way. And their hormone replacement therapy does not work that way. It is an intricate system, and it is an algorithm. And there's a way to do it. And it's simple but complicated.
Right.
And a doctor really has to be passionate about understanding what estrogen does to the mind and body of a woman. And if you've got a doctor giving you hormones as a woman who doesn't understand the natural physiology of the female body. I mean, and Tom, to be honest here, you don't have to dose estrogen in a rhythmic fashion to get to optimum levels. If you know what you're doing. And if a woman doesn't have a uterus, you can't do that for all women, but you can get to optimum ranges if the dose is high enough. And so, like, if a woman doesn't have a uterus, you can titrate a weekly estrogen injection so that she doesn't use the physiological cream. It just needs to be done. But women with a uterus, the best way is the transdermal cream, mimicking the natural physiology, because the entire body cycles too.
Okay.
Even at high doses of a weekly injection of estrogen. It's just what those levels are.
That was, I mean, we're coming up on the question about hysterectomy. So we're a woman with a hysterectomy. What do we, what is that? These are questions from listeners. So this is.
Yeah. Well, a hysterectomy, no matter when a woman gets it, is put in menopause. It's no different than chemical menopause or natural menopause. It's still a pause. It's a state of ovarian dysfunction or no ovaries at all. And even if a woman has a partial hysterectomy and has her ovaries intact, they will shrivel up like raisins in a very short period of time if the uterus isn't there. It's like if there's no uterus, there's no reason for your ovaries to produce estrogen, so the manufacturing plant just ceases production. And then so the estrogen starts to really diminish. So even my doctor told me, oh, you're going to be just fine. We're going to keep your ovaries in, and this is going to be like nothing happened at all. Huh? That is one of the biggest lies. They should see that is, to me, it's like, that's not true. That's not true. And there's lots of studies that support that. You take out that uterus, those ovaries shrivel up like raisins. And it just depends on the state and the health of the patient at that time. For women who've had a hysterectomy, they're going to continue to go into a mental and physical decline because they're not able to produce adequate amounts of circulating estrogen. And they too can get estrogen dominant if they go to doctors who misdose their estrogen. Giving women the same dose of estrogen every day, the same low dose of estrogen every day like that, triggers an estrogen dominant response. There's no way to properly detoxify it out of the system. And so, now these doctors that practice second generation HRT, some of them who have some sort of education outside of medical school are talking about the detoxifying process or the methylation process and the feedback loop and, dealing with all of that. I don't know if any of them have ever had any success with it.
Right.
And yeah, you do need to detoxify estrogen, but if doctors really care about this natural detoxification process, they would increase the estrogen so the estrogen does it naturally. So there's just this exercise wheel of HRT medicine with this low dose hormone therapy and estrogen dominance and this methylation issue and feedback loop that doctors are running around like chickens with their heads cut off trying to figure out. I mean, this isn't even an issue if estrogen is optimal. It's not an issue at all. Estrogen is the natural detoxifier of everything. But when I say that it affects every function in the female body, I'm not lying. If it's dosed right.
Right.
It's just everything is dependent in the female body on estrogen and adequate amounts to function. And so women on low dose second generation HRT will get estrogen dominant. It's guaranteed, especially with pellet therapy. There'll be pellet therapy, you have your own issues where you're actually not given estrogen, and the high dose testosterone actually further suppresses ovarian production. So estrogen gets lower and lower and lower, and FSH gets higher and higher and higher. And the high dose amounts of estrogen or testosterone are now signaling to the brain that the woman is really a man. So, and because these doses stay so high for so long, that this is a transition tends to take place that we've seen in a transgender clinic.
Right.
And, and this is why I highly recommend against pellet therapies for women. This is my personal opinion and a lot of other physicians' opinions who do advanced HRT therapies. I would not recommend that on my worst enemy. Okay, maybe my worst enemy, because it's very painful.
Right.
I mean, if you really want to make a woman depressed, angry, miserable, erratic, just not happy with anything, this is how you do it. You load them up with a pellet therapy from one of these pellet doctors. They don't balance estrogen. They don't even address the estrogen issue, and that's the main sex hormone in women. It's like I use that analogy with the gas tank in the car. It's like, all these doctors keep trying all these different things to get the car to go,
right?
But nobody's addressing the empty gas tank. So you give women healthy amounts of estrogen in the right method and in the right doses, then the body tries to heal itself and it tries to function by itself in the best manner that it possibly can, the brain, the behavior, and the body. It's crazy.
Let's talk a little bit about the relationship between the thyroid and estrogen. And for people out there with thyroids that have been removed, I've seen doctors give women synthetic T4 when they say, hey, I'm not losing any weight. And they see it, so out pops the RX pad and gives them a synthetic T4 to help them lose weight. But of course, if you and I both know if your liver is not functioning and your methylation process isn't working well, the T4 is not going to turn into T3. So it's just going to, it's just not going to work. But let's talk about the thyroid and the estrogen before we move on to progesterone and other things.
We see this a lot in the clinic. A lot of women will come in and say, okay, my doctor says I have a thyroid problem, and they may or may not come in on thyroid. There's a lot of symptomology of thyroid dysfunction with estrogen deficiency symptoms. And it's easy to get confused between the two. And if a doctor doesn't really know a lot about estrogen, they'll just assume those symptoms are for thyroid and they'll prescribe. And they really don't know. All they know is TSH. And so they'll put a patient on the thyroid, whether they need it or not, without checking the estrogen.
Okay.
So there's some women that come in, women who have been told they have a thyroid problem who are not on thyroid. We check the entire panel. We check the thyroid panel, and we also check an extensive hormone panel with estrogen, FSH, progesterone, LH, and the testosterone panel and growth hormone and a few other things. And then we get a true reading on what's going on with all these things, including estrogen, because estrogen does dictate thyroid's function. And so you can give a woman thyroid. So if this patient comes back with having thyroid issues and estrogen issues, depending on the severity of what's going on behind the scenes with thyroid, then the doctor would give the patient a thyroid medication in conjunction with estrogen, if it's indicated. Because thyroid depends on estrogen to function, the more estrogen a woman requires, the more thyroid she's going to require. Like you can't just, when you adjust estrogen to the sweet spot, you can't ignore the thyroid.
Okay.
It's a thyroid problem. You can't, the patient will have problems. So there has to be a titration of both along the process to the sweet spot. A lot of doctors do not know this at all. And then some women who don't have a thyroid, and this is what happened to me. I was put on thyroid medication thinking that I had thyroid issues. We were just looking at the TSH, and there's about 40% of women are in this boat too, that once you get balance your estrogen, then the thyroid symptoms go away, or what was thought as they were thyroid symptoms. Then there's no need for thyroid medication. And so those women can get off of their thyroid medication because the symptomology was related to estrogen deficiency and not thyroid at all. So balancing hormones, finding a practitioner who understands how to balance thyroid and estrogen together is a real find.
Okay, let's talk about that a little bit. I've got a couple other questions that I want to hit, but how does a person go about finding a good physician, or a female finding a good physician for HRT?
Well, what I tell my clients or my listeners, my clients, I get them the practitioners for them. But I tell them the things to look for in their language, whether it's the language on their website, whether it's the language when they call and they ask the receptionist questions. But it's the mindset of the practitioner you really want to know. You want to know what kind of hormones does this doctor prescribe, first, second, third, fourth generation. That's going to dictate what you're going to get in treatment. If you go to a physician who's afraid of estrogen or thinks that estrogen causes cancer and has never educated themselves to know that estrogen is cancer protective and that women are at greater risk of cancer when they become estrogen deficient, you want to go to the doctor that understands the impact estrogen has on the brain and body. If a doctor thinks estrogen is bad or uses first and second generation hormones, your hormone therapy may work a little bit in the beginning, but it will fizzle out, and there will be this exercise wheel of conventional medicine constantly trying to treat the symptoms of your hormone deficiencies. If you go to a practitioner who understands the impact estrogen has, not only understands the impact of estrogen, but the value of estrogen, but more importantly, knows how to prescribe hormones that fixes the estrogen deficiency issue, not just merely dose the hormones in low static dosing to treat the symptoms of estrogen deficiency. You want to go to a physician who actually knows how to dose hormones that makes that crossover, that the hormone dosing actually makes the difference in the brain and body. Underdose hormones, they don't really make a difference. It treats some of the symptomology for a little bit, but never enough to actually change things in the brain and change things in the body and gets the body to do things it's supposed to and think the way that it's supposed to. Only healthy amounts of estrogen does this.
So what are some of the questions you'd ask a physician?
What kind of HRT do you use?
Okay.
Which approach? Do you have any clinical goals that you're shooting for?
Okay, good one.
What kind of labs do you take? If a doctor takes saliva testing, you know that they do first or second generation. If they do blood spot testing or any testing other than blood serum, your hormones will be underdosed because you need that type of testing to microscopically see how much is in your body.
Okay.
Well, if you don't have enough circulating estrogen in your blood, to us, you don't have enough.
Right.
And when you have a doctor's mindset that says, hey, if you don't have enough estrogen in your blood, you can't feel good. Your body's falling. They already know what happens
Right.
to a woman. And then these doctors who understand this impact, usually they try to go find the education or try to figure out how to get this woman the estrogen they need to feel good mentally and physically. And so that's why it's important to ask, do you have clinical goals? We have clinical goals. There's an algorithm. There's a clinical goal that we're shooting for. Symptom speaking, lab work and with clinical indicators. So these women that tell me, oh, I've gone to this doctor and, I have insomnia and I'm depressed and, I have mood swings. But I love my hormone doctor. I'm like, okay, why? Because to us, these are clinical indicators you don't have enough estrogen. These things go away with adequate amounts of estrogen to varying degrees, depending on the patient. But for most women, it fixes these problems. And so, if you go to a doctor that says, well, we don't want to give you too much, ask them why.
Why? All right.
If they say estrogen causes cancer, well, then really, can you show me that study? Because I haven't been able to find it.
I don't think it's out there.
Well, there are studies out there that indicate synthetic estrogen causes cancer, but not even that, really. The dose just isn't. When you keep a woman estrogen deficient, she's just susceptible to cancer.
Right.
And so if you give a woman estrogen, like if you do a study on if estrogen causes cancer or not, and you grab a pool of women, let's just say 50 women that you're going to put on Evamis, and you do this study, the chances of you finding cancer is crazy. But if cancer does come about this, it's not so much the estrogen. The estrogen is just too low. It's not that the estrogen caused the cancer. It's that the estrogen dose too low. I mean, it's just, there's just a disconnect with estrogen. I mean, doctors forget that high dose estrogen was used to treat cancer. It's cancer preventative. It's just, in so many ways, it's cancer preventative. Let me tell you how it prevents endometriosis, endometriotic cancer. If you have regular menstrual cycles that estrogen homeostasis brings, then the lining of the uterus is constantly being fleshed out, very mechanically every month. There's no buildup, but this lining is sloughing off every month because you're ovulating. And to have a healthy menstrual cycle, you need to ovulate. And there's no ovulation without estrogen. So in order to restore ovulation, you need to restore estrogen. And when you're restoring estrogen and progesterone the way that it's supposed to, then the lining of the uterus sloughs off. So estrogen is a great cancer preventative tool for endometriotic cancer. And women are more susceptible to tumors when they're estrogen deficient. In fact, there's studies on that. In fact, there's more studies that show how estrogen is cancer protective than there are that estrogen causes cancer. In fact, I can't find that study. I've looked everywhere. So if listeners know of a study that indicates that estrogen causes cancer, send it my way. I'd like to take a look at it.
Okay.
I want to see, what is that dose of estrogen? How long was it? What were the state of these women? There's many questions to ask. But this is part of what started my research. I was like, how can their brains and bodies actually restore and they heal and they get off of medications and their body's bone density comes back, that they no longer have osteoporosis. I mean, when you actually see and witness these diseases, it makes me ask, why is everybody saying this causes cancer? Because in the 15 years that I've been working in a hormone-only clinic, we would have seen such a high cancer incident rate when every patient you have is on hormones. We're not like conventional doctors around town. Our practice, this is 100% a hormone clinic. So, and from what I see, and being the small town that I'm in right now, you hear about other doctors' patients getting cancer. And, you would think that we would have a higher breast cancer incident rate than any of the other doctors put together. But the truth is we have a lower, and that's why I started this, is because I wanted to show we have a lower breast cancer incident rate with this. That's why I started Panacea Sciences, because of the diseases that go away, including cancer, tumors. When you see things with your own eyes, which is something as simple as adequate amounts of estrogen dosed right,
Right.
diseases that don't exist, it makes me very hard to sit on my hands and keep my mouth closed and not say anything.
Right.
You know,
I don't doubt that. I don't doubt that a bit. All right, let's do this one. Post-menopause, are there natural ways to boost estrogen, progesterone, and testosterone?
well, not circulating levels.
Okay.
You know, you get the bulk amount of, women get the bulk amount of their estrogen from the ovaries. And once those ovaries have shriveled up into nothing, post-menopause would be considered a life stage 6 in the life stage reproductive scale. This means that these women have been without estrogen for a long, long time. And to get their bodies, their ovaries have been shriveled up if they even have any. And so you're never going to get healthy, abundant amounts of estrogen being postmenopausal. And estrogen dictates the functionality of progesterone and testosterone. So most women will be progesterone deficient, testosterone deficient, estrogen deficient. The more postmenopause she gets, because the body, you have to think of estrogen and hormones are messengers that get sent throughout the body that tells the brain and body where a woman is in her state, her life stage of reproduction. And when estrogen is low, that message throughout the body sends the signal that it's time to die. It's time to wither away, shrivel up, and go climb the mountain like they do in Japan and go die. And because the body, brain and body just fall apart, and this is dictated by estrogen. This is what women, there's a lot of women in postmenopause. And a lot of women spend 2/3 of their life in postmenopause. And postmenopause is really nothing but a state of decline, a continuous state of shriveling up to nothing. And that is not a happy place to be. And so, you know,
it does not sound like a happy place.
You couldn't, but that's why old women are hard to deal with. And I'll tell you, well, the old women with some fat on them do benefit from the estrogen they've stored in fat.
Okay.
That's why you see more, the larger, older women tend to be a little more jolly.
Right.
You know, but the old shriveled up woman at the same age is bitter and sharp and harsh and no muscle tone, no fat, no subcutaneous fat. And those women are harder to deal with. At least the heavier set women and menopausal women, you know, have some estrogen redemption. A little bit of estrogen is better than no estrogen.
Right, right. So you kind of estrogen, progesterone. Estrogen pretty much is the leader of the pack as far as the rest of the hormones go. Yeah,
and I know you've heard me say this before, the relationship, and I mostly talk about estrogen because you can talk about estrogen as the leader of the pack because it dictates how all other hormones function, especially progesterone.
Okay.
You know, they are to be looked at as one main sex hormone, but when estrogen's deficient, nothing else is going to work, not even progesterone. But if progesterone is deficient and you have enough estrogen will work. So, and progesterone doesn't dictate the functionality of the other hormones like estradiol does. And so you really need abundant amounts of estradiol circulating in the blood for progesterone to work the way that it's supposed to and to be the calming, supportive, and nurturing hormone it's supposed to. And so, you know, progesterone still, the jury's still out on progesterone. It does have some temporary calming effects for some women, but it's still a problem hormone that needs to be adjusted and maintained and attention to. And it's still one of the things that we're trying to iron out. You know, we've got most of the Wiley protocol clinical flaws dialed in with some good clinical navigation with prescribing, but still progesterone. There's some women that still might get a little luteal phase lethargy or a cramp on their first day. But for the most part, those are really their only negative indicators if estrogen is right. So, estrogen and progesterone are like yin yang. They are to be looked at as one main sex hormone, especially if a woman has a uterus. You never want to give a woman unopposed estrogen with a uterus. It's questionable without a uterus, but especially with the uterus, because you need that progesterone to maintain that healthy menstrual cycle. And you need that peak of progesterone in the luteal phase at day 21 to downregulate the estrogen receptors so women can properly shed the lining of their uterus. Because if women aren't getting this luteal phase peak in their progesterone, they're not able to downregulate the estrogen receptors to be able to shed that. So that's also a contributor to endometriosis. And so the goal is to have a healthy, as you can see, me talking about menstrual cycles, right. The healthier the menstrual cycle, the healthier you can shed the lining of this uterus, which is dictated by estrogen levels, the healthier a woman can be. She's in a state of reproductive prime. The goal is to put a woman, take her from, life stage 4 or 5, perimenopause and menopause, and put them in a life stage of 3 of reproduction and keep them there. And you do this with optimal levels of hormones indefinitely. So if you keep a woman in her state of reproductive prime, having healthy menstrual cycles, her brain and body aren't falling apart because those levels, again, like I said, they're messengers. So those messengers are sending signals that this woman is in a state of reproductive prime, so she has to have enough muscle tone. She has to have enough muscle mass, not too much fat, a wherewithal of her brain, cognition, the ability to think on her feet, the ability to have the energy to chase her small children around. I mean, all of this is designed for a woman in a state of healthy reproductive prime to reproduce and take care of her offspring. And so whether a woman reproduces or not in this state, no matter how old she is, when she runs out of eggs, she can't get pregnant. And you can actually dose these hormones to work as a birth control pill where you lower the LH in the luteal phase so she can't get pregnant. I mean, there's ways that you can do this, but actually our HRT system could be a birth control method. The intricate dance between estrogen and progesterone helps regulate these menstrual cycles, and both of these hormones have to be dosed to optimum levels in the right amount and cycled in the right way so a woman can have this healthy menstrual cycle.
All right. I've got 2 more questions, then we can wrap this up for today, and we'll be back for another episode of the series on healthy menstrual cycles, which we'll cover again in another episode. But what can a younger woman do to prevent this chaos from happening?
Well, younger meaning what, like puberty through college age?
Yeah. One of the things that come to my mind is, stay off the birth control pills.
Oh, yeah. Young women are not really taught how to take care of their bodies or the significance estrogen has to their brain and body. And usually in this generation, as you see, and what we see a lot of, in fact, our clientele is getting younger and younger and younger. These young women are starting out with endocrine dysfunction. And their ovaries aren't able to produce the amount of estrogen that it should. And so they have irregular menstrual cycles. And because they usually live with family who are dealing with their mood disorders and listening to the griping about the physical pain that estrogen deficiency brings to a woman during menstruation, then, let's send you to the hospital. Let's go. You're depressed, you have anxiety, you have horrible menstrual cycles, or let's take you to the doctor and put you on something. So these young women are put on birth control pills and antidepressants, anti-anxiety, ADHD medication, all these estrogen deficiency symptoms that they're treating. They're put on all these medications. Well, the birth control pill further shuts down their ovaries, so they're put in chemical menopause. And what young women need to understand is being in menopause for most of your life does not make a happy woman, no matter how old she is. And if you ever read the package insert, you can probably look one up online for birth control, all the warnings and the side effects and stuff, all of those are all symptoms of estrogen deficiency. And what happens to old women when they lose estrogen, that's like being in menopause. But they don't say, this pill is going to put you in chemical menopause. You're going to be in menopause. You and your grandma are going to feel the same. So women need to understand that the health of their menstrual cycle is going to determine the overall health of how they feel mentally and physically. if they stay off of birth control pills and stay off of processed foods, they stay off of the xenoestrogens and the phytoestrogens and the fake estrogen, that's a big plus.
Okay.
There's many things a young woman can do, and I'll talk more about those extensively in your next show about healthy menstrual cycles. But I'll be giving more detailed things that women can do, a list, a punch list on the things that they can do to do this. But you also have to keep in mind, Tom, that these women are born with ovarian dysfunction from the get-go. The chances of a young woman having a healthy menstrual cycle this day and age is slim to none. So these young women are already born estrogen deficient. They're not producing enough estrogen to even make it through puberty to be in a state of reproductive prime. So they go from a reproductive or a pubescent transition into a state of perimenopause, never really producing adequate amounts of estrogen like generations before us were able to. And so the goal really is these young women may have to get on some sort of HRT long before they thought.
Right.
That's really what's happening.
Oh, it's pretty sad. I mean, I see a lot of young women get handed birth control pills because they have PCOS.
Well, because I tell you something, one of the most debilitating conditions a young woman can have is PCOS.
Right.
It makes a woman crazy. It's horrible. It's the high testosterone, usually high progesterone, low estrogen. These women are not happy. They don't sleep. They can't lose weight. They feel just horrible for no reason. They can't understand why they feel so bad when everything is going. They have a good life. They exercise. They eat healthy. But yet they still feel horrible. And doctors are not taught in med school what to do with PCOS other than to manage the symptoms with drugs. And, you know, PCOS is a transgenerational disease. It is handed down. It's not necessarily something that a woman develops so much as it's something she's born with. And, you know, you can't reverse it. You can't get rid of it. You have to manage it. And, you know, PCOS happens in 1 in 4 women. Patients with PCOS are a more unique breed, and we put them in a different clinical category. We have categories of patients in HRT because it's complicated. Balancing hormones for a woman with PCOS is different than balancing hormones for a woman with endometriosis. There's just different approaches. Endometriosis, you can get rid of endometriosis to varying degrees for most women, but PCOS you can't. It's something you have to manage. And you have to deal with the cysts on the ovaries. When you put a woman on PCOS, like doctors put women on PCOS on birth control pills, we put on hormone replacement therapy.
Right.
Because women with PCOS are anovulatory. They don't ovulate. And when you don't ovulate, you don't have regular menstrual cycles. When you don't have regular menstrual cycles, you feel horrible. And so the quickest, most effective way to get a woman with PCOS to ovulate is to restore estrogen, to restore the ovulation with estrogen. And then once you get the cycle functioning the way that it's supposed to, and the shedding of the lining of the uterus sheds, and she's used to this regular functioning menstrual cycle, the depression goes away, the crazy goes away, the mood swings, because women with PCOS, they are severely not happy. They have daily PMDD, not monthly PMDD. I'm talking daily PMDD, where they just have a very difficult time getting through their day. And the diet does play a big role with that, as well as their sleep hygiene and their physical activity. So those are the 4 main factors how we address PCOS: hormones, sleep, exercise, and what are you eating?
All right, last question for this day. And I know Dr. Nagel's a big fan of this also because you've mentioned it, but partnering with a health coach to help manage this and work forward to reaching that hormone sweet spot.
Yeah, working in a hormone clinic all these years, we've had health coaches that we've trained on to be good health coaches. There has been a health coaching movement over the years, just the past 5 to 10 years, really. And they're very useful because the doctor can only do so much in their visit with the patient. The doctor's role really is to order labs, read the labs, write the scripts for the hormones. But everything else, it's just not cost effective for the doctor to be spending the time that's needed to educate the patient about the diet. Why is it important to eat animal fats with hormones? Why is it important to eat or sleep when the sun is down? Why is it important to exercise and pump blood throughout the system? You need somebody to explain to the patient the importance of circulating estrogen in the blood and what foods will impact the hormones, the optimal clinical efficacy of the hormones. Like my job in the clinic, Dr. Nagel would see the patient. My role in his job was before Dr. Nagel would see the patient for a new patient visit, then he would refer them to me to do what we called an intake. And then I would tell them the different types of HRT that are available and what the costs are and what they can expect with each method, what insurance pays and what they don't pay. And then the patient decides what kind of HRT they want. And then when they go see Dr. Nagel for the hormones, then they come and see me after they see Dr. Nagel, and I walk them through the process of what they should be eating, how they should be sleeping, what they should be doing to help the hormones that they got from Dr. Nagel to work better. And there are diets and guidelines that we've seen in the clinic that help this happen. And it isn't just one diet, and that you have to really understand your patient and where they're coming from and what they're able to do. Because an extremely estrogen deficient woman coming in is probably not on a good diet and not on an exercise program. And you really do need to work with this woman with her hormones and understand how the hormones are going to impact them along the process. So you can't be cracking the whip on your patient who just started the first dose of estrogen, and who's never moved. You might have to wait a little bit, a few cycles, for them to get enough estrogen in their system to be able to even have enough energy to be able to go out and do that, or enough motivation. Estrogen is the motivator, and estrogen naturally increases energy organically. So women are you get more out of your patient when they have estrogen and then if they have enough estrogen in their system, when they do make these changes, whether they're working out or they start incorporating yoga or strength training or cardio, it makes a greater impact on their body in a positive way, in a more profound and prolonged way. So when you start making this transition, then a health coach who's trained to be a clinical hormone coach in advance, like I am, which I do, I'll be having my classes here real soon, you're able to not only coach the patient on hormones, any type of hormones, but also what foods to recommend and how and when to recommend these things and what this titration looks like in this process that we call the Panacea process to that hormone sweet spot. What do you do at this visit? What do you do at visit 5? What do you do at visit 12? All the way to the sweet spot. And so Dr. Nagel loves working with me because he doesn't have to he doesn't have to hire somebody to, who doesn't bring money in. It's an expense on the office to have somebody come in and talk about these things. And so if you can hire a coach who's been trained how to do this, he needs more coaches. He needs me to train more coaches. I cannot handle the patients that come my way. And so if women understood how to get patients' hormones to their sweet spot, working with a physician who does, the right hormone replacement therapy or any hormone replacement therapy, it's a benefit for not only the patient of getting to their sweet spot quicker, faster with a cheerleader, and to get there, it's a benefit for the physician. They can just go through, see the patients for hormones and know that the coach that they're referred to knows what they're doing, and they work in unison. And I also work with the compounding pharmacy with the hormones. So I answer questions and I'm the liaison between those. I'm the liaison between the compounding pharmacy and the HRT physician. And so having a health coach who understands hormones it's a big deal. It helps patients get to their hormone sweet spot and everybody wins, really.
Marie, where can people find you?
Well, they can find me online on menopausemoxie.com, and I'm on Facebook under Moxie, Menopause Moxie. If you Google Moxie Menopause or Menopause Moxie, I come up. Unless I've been bumped down, who knows? I'm a Republican.
No, you're still out there.
You never know. And you can follow. And one thing I do want to mention, I know I say a lot of things, Tom, that are, make some people mad. I hear it all the time. There's a lot of studies that support what I say, and there's a lot. And so when people say, well, do you have any studies? I'm like, what am I supposed to do? Send you my whole arsenal? I mean, it's like, and you're going to read them through and then decide if that's going to be your answer or not.
Right.
So what I did is I started a Facebook page called Panacea Sciences, and I'm not sure I think you follow it.
Absolutely.
All my studies. I mean, I've done a lot of research, and I have thousands of studies that talk about PCOS, endometriosis, menopause, perimenopause, estrogen deficiency diseases, estrogen, the gut microbiota, and menopause prevention, and so on and so forth. I post all these studies. I post anywhere between 1 to 4 a week. Lately, it's been about 3 a week. I do have an assistant that's helping me schedule those posts. But this is where you're going to find your information. Right. And you can hashtag if you want to know more about something. I do try to hashtag those pretty well. So you too can have access to these studies that I've come across in my years of research. So you can find me at menopausemoxie.com or at panaceasciences.com.
Okay. All right. Thank you, dear.
Well,
it's nice to see you. We'll be back for the episode on healthy menstrual cycles. I put that away for a minute. I got to pull that.
No, that's okay. I'll tell you, this next episode is for these perimenopausal and menopausal women who have their daughters who are in this menstrual dysfunction. So really, this is really, even perimenopausal women, how to establish and maintain a healthy menstrual cycle is really important. So I look forward to that show with you.
Thank you for joining in today with the Rebel Health Coach, Tom Underwood. And be sure to subscribe to the show so you can catch all the episodes. With desire and commitment, you can implement a lifestyle of wellness and fitness. For the support, encouragement, and tools you need to be successful, visit tomunderwood.net.